All right, welcome everyone to the August 2021 edition of the Prehospital Care Research Forum Journal Club podcast. The Prehospital Care Research Forum is dedicated to the promotion, education, and dissemination of prehospital research. And we believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine prehospital emergency care. And here, with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Remley Crow, and I am joined today by Dr. Tony Fernandez and Jeff Rollman. And it is my great pleasure to welcome a couple of the authors from our paper today, Dr. David Miramontes and Dr. Dave Wampler. Is that Dave squared then?
Dave Wampler is the square, and I'm Dave Miramontes, yes.
Perfect. So as a reminder for our audience, the name of the article we are reviewing is Paramedic Utilization of Vision, Aphasia, Neglect VAN Stroke Severity Scale in the Prehospital Setting Predicts Emergent Large Vessel Occlusion Stroke, and that was published in the Journal of NeuroInterventional Surgery. As always, this discussion is paired with a column by our very own Dr. Tony Fernandez in EMS World called Journal Watch. And we encourage all of you to check out that article at emsworld.com, and it'll be under your category Education and Training. And I want to thank all of you for joining us today. As we begin, I want to remind the audience that you can use that chat feature on your screen and type in questions and comments as we go, and we're going to bring those into the conversation. And with that, I think we should go ahead and kick this off. And, since we have some special guests here, let's get started with some introductions. Dr. Miramontes, could you tell us a little bit about who you are and what your involvement in EMS is?
Sure. My name is Dr. Dave Miramontes. I'm an assistant clinical professor at UT Health at San Antonio, University of Texas. But I'm the medical director for the San Antonio Fire Department, and I do a lot of work with STRAC, which is the South Texas Regional Advisory Council, which is the coordinating body of 22 counties in South Texas, all the way from basically San Antonio to the Mexico border.
Fantastic. And Dr. Wampler, could you tell us a little bit about yourself and involvement in EMS research?
Hi, I'm David Wampler. I am a professor in the Department of Emergency Health Sciences. I'm a paramedic. I cut my teeth as a paramedic in the Kerrville Fire Department. I spent about a decade there a long time ago. But I am currently the Director of Clinical Research in the Office of the Medical Director with Dr. Dave Miramontes.
Awesome. Well, we are over the moon that you are both here. So thank you for taking the time to talk about this great work with us. We're very excited about your paper, and congratulations on the publication.
Well, thank you.
So I want to get straight into today's topic because it's one that's definitely near and dear to me. I mean, it seems like everywhere we turn, there's a new stroke scale, CPSS, RACE, LAMP, CSTAT. It's all alphabet soup. And, today's article looks at one of the newer stroke scales, the VAN, the Vision, Aphasia, and Neglect Scale. So some of our listeners may not actually be familiar with the VAN because it is a newer scale. So could one of you just walk us through how that scale works? So how do we apply it in the pre-hospital setting?
Yeah, I'll take this one. So the VAN score, we are looking for a stroke severity score. So we use BFAST, balance, eyes, face, arm, speech, and time last Noel as our screen. And then for our stroke severity score, we chose the VAN score. And there are other ones out there, CSTAT, RACES, all these others. But we had three criteria that I basically had a fight with our neurologist about. And that is, it had to be simple, no math, and they had to be able to easily teach it to paramedics. So, and the other one was, score sheets, because we are an all electronic organization. So the VAN is Vision, Aphasia, Neglect. And you can go to strokevan.com. It's the creator of the VAN score, Dr. Taleb, has a great website, and he has an app actually that has all the stroke score on it as well. So VAN is, first of all, you have to have arm weakness. So unilateral arm weakness, and what that then starts down the path of three quick assessments. Vision, do they have a visual field deficit? Do they have a fixed gaze? Or do they have double vision with extremes of gaze? Follow my finger, and then you look, too bad we don't have Zoom, I could demonstrate it, but basically follow your finger to the extremes of gaze each side, and if they get double vision, then that's a positive. Aphasia. Aphasia is not slurred speech. Aphasia is a disorder in language. So there are 3 tests to try and figure this out. You have the patient open and close your hand. So you show them the command and tell them the command, and they should repeat it, open and close the hand. Second, you show them common objects, a pen, a watch, a badge, and you ask them to say what it is. If you hold up, a watch and they say, oh, it's binoculars, well, obviously they've got expressive aphasia, okay? And the last thing is you have them say, today is a sunny day. And what you're working about is not slurred speech. So if they say, with slurred speech, that's normal as far as the aphasia screen is, because they were able to repeat the language. And then neglect is either a fixed gaze off to one side and they ignore one side, or they totally disregard one side of the body. It's usually the paretic side. So if any one of those V, A, or N, vision, aphasia, or neglect, is positive, along with left arm weakness or right arm weakness, then we could say that this is a severe stroke, and it probably is a large vessel occlusion. And in our city, we use that to triage them to a comprehensive stroke center. Now, some cities have a comprehensive stroke center everywhere, right? There's one around every corner, or it's close enough that they can go to a comprehensive stroke center for every stroke, like, for example, in Peter and Debbie's district. But for us, it's a trip. So it's potentially a 20 or 25-minute difference in transport time in Bexar County to go to a comprehensive if they're in the extremes of the county, because all of ours are located in one place. So we use this score to triage patients who are last known well less than 6 hours and are VAN positive. We take them directly to a comprehensive, bypassing multiple primary stroke centers so that they get the best possible care for their large vessel occlusion.
That's fantastic. Thank you for the excellent explanation. And I want to emphasize a few of the things you said, and thank you for sharing the website, strokevan.com. We'll make sure to include that in our show notes. And Dr. Taleb has an excellent book on stroke as well that I would recommend, and I'll include that in our show notes. So a couple of the things I wanted to highlight that you said are, there's some really favorable characteristics about the VAN, and there's actually a good meta-analysis out there, I guess, or maybe systematic review on what makes for an excellent pre-hospital stroke scale. And you hit a lot of those points with the VAN. One is that each letter stands for what it is. So VAN is vision, aphasia, neglect, easy to remember for something that we don't maybe see all that often. And that there's no complex scoring or score sheets. I think those are critical characteristics. And it also includes some of the signs that research has shown are very associated with the more severe form of stroke with large vessel occlusion. And those are called the cortical signs. So things like those changes in vision, aphasia, neglect. So that was really excellent. Now, another thing I want to talk about is just, why is it so important now to identify LVO stroke specifically in the pre-hospital setting? It seems like just recently the emphasis has been out there on, first we were just trying to find any stroke. We'd do the FAST and say, yeah, we're just going to stroke. But I'm curious, I would like to hear more about your thoughts on why all this emphasis on LVO now.
Yeah, so the large vessel occlusion, before we didn't have a treatment for large vessel occlusion other than giving thrombolytics. So now we actually have something else. We can take a patient to the brain lab. That is, that if you have a large vessel occlusion confirmed on CAT scan angiography, and it's less than even 24 hours of onset of symptoms, you can take the patient to the brain lab. They can do a angiography and actually suck the clot out of either into the cerebral vessels, specifically the M1, M2, or M3 segment, or the basal artery. We know that in these large vessel occlusions, TPA, TKNase, or Retivase does not work well for large vessel occlusions. And now we have another therapy going to the brain lab and actually suck the clot out that we can do. And this has been proven in the DAWN trial, even up to 24 hours after onset of symptoms. If there's a watershed area of the brain that hasn't infarcted, they can actually make a difference and improve outcomes by even 6, 18, 12, or 24 hours after onset of symptoms. So before, if we had a wake-up stroke, for example, if they were VAN positive, we just put them in the hospital and say, oh, sorry about your luck. Well, now we can take them to the brain lab and actually suck the clot out and maybe get improvement in their outcomes.
That is a really important point. And you mentioned earlier, knowing what resources your system has is really important when making these decisions. And in the paper, there's another important concept I want to highlight in that background section on why not just take them to the closest hospital first, get them imaged and get them on their way. The paper mentions in the background that there's sometimes delays with getting patients in and out of the hospital. And is that something that you all have weighed as well?
Yeah, so that's a big, so what we call door in, door out. So if you went to one of the hospitals in the periphery of the county, not a comprehensive, it can take 2 hours, 2 hours and a quarter to get them through the initial scans, evaluation, TPA, and then call a transfer critical care ambulance to take them up to another hospital, which may be 20 minutes, 25 minutes away. That door in, door out time is up to 2 hours, and that's wasted time when these patients should have been in the lab in the first place. So we bypass hospitals to go to a trauma center. We bypass hospitals to go to a STEMI center so they get angioplasty. So why not bypass primary stroke centers to go to a comprehensive stroke center where you can get the definitive therapy? Also, and I'll have Dr. Wampler talk about this about our study, is we also found that the VAN score predicted bleeds. And again, a patient with a brain bleed needs to go to a neurosurgery center, which happens to be in our organization the comprehensive stroke centers. So not only did it work for strokes, it also worked for Bs, for bleeds as well.
That's an excellent point, and we'll definitely talk about some of those results because I think it was really interesting that Van also picked those up. So I think that means we should just dive right into the objective and methods. Again, the authors were looking at testing out the VAN in its real world context in the pre-hospital setting. And we've talked about this on the podcast a couple of times about how important it is to test a scale where it's going to be applied. So the original VAN study was conducted in the emergency department, by trained nurses. And now this study takes it out of the ED and into the pre-hospital setting where you have things like mimics and you have intracranial bleeds. And so I think that this was a really important way of looking at this. And this was prospectively collected data with a focus on research. So we get some of those high quality outcomes that we might not have been able to see before. And again, the authors should be commended for this level of work. It's no easy feat. And so I'll turn it over to Dr. Fernandez, who will go through a little bit of the methods and how the authors set this study up to answer the question of whether or not the VAN can predict LVO in the pre-hospital setting.
Well, thank you, Dr. Crow, and thank you again to our authors for joining us today. I really do appreciate it, and I thought this was a very interesting, valuable study. Excuse me. So one of the things that Remley just mentioned was how important it is to test things in a real-world setting. So I think we'd be remiss if we didn't start off by talking a little bit about the setting of the study, where it took place, and if you could tell us something about your stroke system of care. I think I might have caught someone on mute.
Sorry, I'm having a little bit of audio issue. Were you asking me a question?
Yeah, thanks, Dave. I was just, we were going to dive into the method section of your paper a little bit, and I wanted to just start by talking a little bit about the setting and your regional advisory council and your stroke system of care.
Yeah, so
not all are familiar with the great country of Texas, and I know Dave Wampler likes to talk about this.
The Republic of Texas.
There we go.
Is broken up into a bunch of regional advisory councils. And we just happen to sit in the Southwest Texas Regional Advisory Council. We call it STRAC. And Dr. Miramontes talked a little bit about it already, but it's 26,000 square miles, which if STRAC was a state, it would be the 40th largest state in the United States. So we're bigger than 10 different states. And we have 3 comprehensive stroke centers in our state. Sorry, in our RAC. And all 3 of them are located in one immediate area. I mean, you could stand on one hospital and throw a biscuit and hit the other 2. So what we elected to do, this actually set up a really nice sort of natural experiment. So what we selected to do is all of the EMS agencies, well, specifically the two largest EMS agencies, San Antonio Fire Department and Acadian, we wanted to look at those agencies that were transporting to this area, not because we're bypassing, but because that is just the natural destination for those patients. So the general setting is we're a large urban EMS system. We use two different EMS systems. Acadian is the primary 911 provider for everything that is not incorporated San Antonio, and then San Antonio Fire Department is the rest of those patients. We looked at all three of our comprehensive stroke centers. Again, they are clustered in sort of the northwest corner of San Antonio. And so, again, it's sort of set up a nice little catchment area for our stroke patients.
Yeah, thank you. That was a great explanation of where the study took place. And so before folks started using VAN in your region, obviously they had to do some training, and I thought it was interesting. You had a 45-minute session that included some in-person and interactive videos followed by a post-test. For folks interested in implementing something like this, maybe you can give us a little overview of kind of how that training took place, what was included, and how it was received by your medics.
So we did our training in sort of two phases. We took our medics that are primarily assigned to our catchment area, and we did face-to-face training. That included about 30 minutes of didactic, sort of explaining the, we talked about the fact that historically we've used the Cincinnati Stroke Scale, and that's really good for stroke yes or stroke no. Big stroke, little stroke, don't care, stroke yes or no. And the fact that now we need to be able to figure out the difference between a big stroke and a little stroke so we can triage them to the appropriate places. So the didactic was really focused on the whys, the when, the where of performing the VAN. And then there was about a 15-20 minute practical application where we actually went through and did assessments on, fake patients, model patients. And it was really pretty well received. Now, because of our organization and our structure, not only did we have to train up the medics that are in that immediate catchment area, but we also needed to train up everybody else. So we also had a distributed learning model where we had the same didactics, but it also included some sort of on your own just-in-time training as well.
That's great, and yeah, it seems like it was well received and effective, so that's awesome. So your study was from June 1st, 2017 to, and then from December 31st, 2019, you had all the medics required to perform a VAN whenever a stroke alert was initiated. Can you tell us a little bit about how, you talked a little bit about how you already had to use the Cincinnati. What other components did you have in your initial stroke alert, and how was that augmented by the addition of VAN?
So at the time of the study, we were basically doing fast-based arm group speech and time. And again, that's sort of stroke yes and stroke no. And then they had to be within the last 6 hours. The last known well was within 6 hours. And finally, the blood sugar had to be what I call non-contributory. I don't want to call it normal because I don't think a blood sugar of 450 is normal, yeah. But it shouldn't look like a stroke yet, right? A blood sugar of 1200 could absolutely look like a stroke. A blood sugar of 20 could absolutely look like a stroke. So if it's between 60 and 600, that's the sort of the parameters that we use for blood glucose. So if they meet the physiologic criteria and they meet the time criteria and their blood sugar is non-contributory, then we call that patient as a stroke alert. Our practice is that patient now must go to the closest appropriate either primary or comprehensive stroke center. They were also required to do a VAN. At the time of the study, we were not bypassing patients. So we were just transporting to the closest appropriate, either primary or comprehensive. Just so happens to be that all of our comprehensives have their own natural area that they're going to attract patients. So all those patients that were identified as a stroke alert, they had the paramedics did a VAN assessment, and it was either VAN positive or VAN negative. And we did also capture in the electronic medical record the individual elements, so that we knew, if 90% of our VAN positives were a single element or multiple elements such as that.
Yep, and I think you made a really good call out there. One of your exclusions was last known well greater than 6 hours, even though we have up to 24 hours. And that, for anyone out there listening, that was because of the stroke alert. So that kind of forced your hand there, if I'm right. Can you talk a little bit about that exclusion and whether you think that how that played into your results?
Yeah, the 6 hour was just a historic relic. It was, at the time, that was our stroke alert criteria. We now know that VAN positive patients that are up to 24 hours can still benefit from intervention. But at the time, we didn't even know if VAN was going to work for us. And so we weren't bypassing patients at the time, and we weren't activating stroke alerts if they did not meet our stroke alert criteria. The VAN was just sort of tacked onto the top of our natural processes.
Yeah, that makes perfect sense. I thought one of the things that was really interesting and useful was the wealth of outcome data you were able to obtain from your hospitals. I'd really be interested in knowing, there's a lot of folks who are interested in doing studies like this, but they don't necessarily have access or the relationships built to obtain these outcome data. So if you could give us a little bit about how you obtain these outcome data and what all elements you were able to collect from in-hospital that facilitated your analysis.
So that's the beauty of being in STRAC. We have a process improvement committee, a stroke committee, and all 3 of our comprehensive stroke centers are already submitting PI data to the RAC. And so they were already used to sharing data with us. And so it was just a couple of additional data elements that they were going to have to provide us. That's also sort of in lies how we designed the study, and that we were looking specifically at our comprehensive stroke centers, because we don't have as clean of a data set that comes from our primary stroke centers, because we just have so many of them, and they get unwieldy when we start talking about human subjects and research and all that kind of stuff. Our comprehensive stroke centers are very much used to dealing with that level of data analysis. So it wasn't a stretch for them. And so because they already participate in the process, they were also integral in designing the study, and they really had personal vested interest in getting the patients to the right hospital at the right time, right? They want those large vessel occlusive strokes to be able to come to them without having to go through the transfer process. They want them to come directly. So they had a vested interest also in participation and validating this particular study for us.
And on top of that, they used the Get With the Guidelines data set. So moving data was not hard. And again, these comprehensive centers are part of a hub and spoke model. So they had affiliated smaller hospitals or primary stroke centers that are part of their system. So Methodist has 6 other facilities, Methodist has 4 other facilities, and then the university gets strokes from various numbers of outside regional centers. So they had a vested interest in trying to make the system better to improve patient care.
That's a really important point. You mentioned the Get With the Guidelines. I don't know that all of our audience may be familiar with what those metrics are. Could you talk just a little bit about what that means for EMS and hospitals?
Yeah, sure. So Get With the Guidelines is a vendor product through the American Heart Association that collects data similar to the CARES database for cardiac arrest, or the American College of Cardiology database for chest pain and for PCI. And what it does is it collects key data elements about the stroke patient's performance. And actually it does collect pre-hospital data from the run sheet. And then the coordinators abstract data from the hospital chart, including their outcomes, what their NIH stroke scale was on arrival, what it was after treatment, and what their rank and score was, or their ability to function after discharge. Were they gravely disabled, went to a nursing home, went home with assistance, or walked out of the hospital normal? So all of that outcome data is neatly organized in a data dictionary mandated data set with cross-checking, and it really helps us a lot with our process. And at STRAC, we actually do a reverse download from Get With The Guidelines into our servers, and then we can benchmark our hospitals against each other to see how they're doing.
What a great resource that is. I mean, that is just right for research and improvements in patient care. So yeah, I commend you for that. That is super awesome. So one more thing before we start moving on to the results. One of your analysis focused on a comparison between bands and an NIH stroke scale score of greater than or equal to 6. Some folks on the call, again, budding researchers, may not be familiar with the NIH score. So can you tell us a little bit about, one, why that's an appropriate comparison, and why the cutoff of 6 was appropriate as well?
Yeah, so 6 is usually a moderate to severe stroke, or above 6. And traditionally, you gave TPA above 6 back in the day. But now we know actually that based on the disability of the patient that presents, clinicians can and should give thrombolytics to patients even with low NIH scores. For example, if you're a singer and you have aphasia and that's your only score, you'll have a very low score, but that will be disabling. If you're a painter and your right hand doesn't work, then your NIH scale might be low if you've got a fumbly right hand. But if that's your painting hand, you're going to need that full function restored. So even with a low NIH score now, we are using thrombolytics and aggressive treatment based on the disability and the patient's outcomes. But generally speaking, an NIH score greater than 6 is a moderate to severe stroke.
Very good, thank you. And one of the reasons why, and correct me if I'm wrong, but the reasons to not simply use the NIH score is just because some of the components that are collected are not, they aren't, you can't really collect those pre-hospitally.
Yeah, it's not. Right. It's just not appropriate. It's a multi-page. You have to have visual aids. It's just not. It takes too much time, right? It's just not appropriate for EMS. There's math involved, and there's so many different pieces. I'll give
you an example. I had to recertify the NIH stroke score just last weekend. It took me 2.5 hours of continuing education with testing in 6 patient scenarios to get certified in using it. So it's a very difficult, cumbersome. I mean, this is physician, neurologist level assessment, which is very difficult to do.
But makes for a great comparison for another stroke score. So I thought that was a really wise decision. Finally, I know I just wanted to mention that we talked about a little earlier that the VANS does well in not only identifying LVO but intracranial hemorrhage in previous studies. So you had 2 outcomes that you looked at. You look at LVO alone or LVO and any intracranial hemorrhage. I just wanted to make sure our audience was aware of that. Don't know that there's anything to comment on there unless you see fit. Please do.
So really, it's big stroke, big bleed, don't care, got to go to the comprehensive stroke center. So if it can identify both or either, then it's getting the patient to the right facility, and that's the important piece.
Absolutely. Well, I always have the unenviable task of holding us up from getting to the really exciting results. But before I let us move on, I just want to open it up to the rest of our panelists. Are there any other questions that relate to methods before we move on to these really interesting results? Okay, well, hearing none.
Sorry, this is
Oh.
Jeff here. Yes, I had one question about the training utilization of the system. Once again, thank you, Dr. Wampler, and thank you, Dr. Miramontes, for sharing this great work. So I understand you had trained several hundred paramedics in the system. I was wondering the role of BLS, since we know that strokes oftentimes are not dispatched as a stroke. They can come out through 911 and many other dispatch codes. I was wondering, were EMTs trained in this? Is there kind of any role of BLS, since it seems like many paramedics are in San Antonio, but rural areas might kind of rely much more on paramedics to be doing all this, sorry, on EMTs.
Yeah, so our system is primarily we have two paramedic engineers. You know, they're first level officers on every paramedic unit. So we have a very ALS heavy system. Our stroke system actually starts in dispatch. So every dispatcher in our fire dispatch center is a credentialed paramedic with at least 7-8 years of experience. So our stroke assessment actually starts at the 911 call. Then we have first response, which is BLS or ALS. About 80% of our engines or ladders have a paramedic on it. And then it was followed by the transport unit or the medic unit with 2 medics. So we did not use BLS training in this study. Since we're heavily paramedic, but that's not to say you couldn't. That very well could be used as a stroke severity score, but I'll tell you that the training would be a heavy lift at the BLS level. It could be done. It could be done very well, but it would be a lift.
Yeah, thanks for explaining that.
But there's really nothing ALS about the van, right? It is just a good, high quality patient assessment that could easily be taught to BLS.
Yeah, I agree. I mean, I could see this definitely a role in rural areas where those comprehensive stroke centers are way further, and those rural EMTs can make a huge difference if they can catch that elbow early on.
Or a bleed.
Or a bleed.
Exactly. Yes, thank you.
I think that's a fantastic segue into the results. Let's see how this thing worked. I'm going to flip us. For those who are listening later, we're going to be flipping through some of the tables, but we'll make sure to say them out loud so that you're able to check them out as well. And this is an open access article, which is really nice. So if you go to PubMed and look up this article, you're able to download the full PDF for free. Definitely recommend checking out the full paper. So let's just dive right in. There were 290 cases that made it into the analysis population. And table 1 is just looking at van assessment by final diagnosis. And so again, we heard about the criteria that were used to bring patients into this study population. So there was suspected stroke and van was performed. And now we have, well, here's the real world. What do we see? And maybe I'll let the authors walk us through some of their high-level thoughts on this table before I dive into my own questions. So either Dr. Miramontes or Dr. Wampler, what did table 1 say for you?
Go ahead,
So
Wampler.
if we are going to design a test, we want to design the perfect test. It is going to be 100% sensitive, 100% specific, meaning it will only be positive in patients that have this particular disease. It will only be van positive for the large vessel occlusions. It will only be van negative for the non-large vessel occlusion, for the small vessel occlusions. So if that's the perfect study, the perfect test. We don't have that. We have a test that is pretty sensitive. The specificity leaves a little bit to be desired, but that's just looking. This first table is only looking at what EMS found in the van. You can see down the table things that were called a stroke alert that weren't actually strokes, right? There were a few TIAs. Some of those were van positive, some of those were van negative. Now that's a little bit of a quagmire, because are some of those actually strokes that just didn't last long, which is the definition of a TIA, but would those have been accurately called had they been either, large vessel or small vessel, van positive or van negative, would they have been correct had the symptoms persisted into what would be meeting the definition of a stroke? It's an interesting question. We weren't able to get at that. But you can also see we had some seizures, some patients with just some altered mental status, complex migraines, conversion disorder. So there were quite a few other stroke mimickers that got grouped up into this to the stroke alert.
Absolutely, and I think that is the point to emphasize. A lot of these scales get validated within stroke trials of patients who are known to be having an ischemic stroke already. And so when you take it out in the real world, it's not necessarily surprising to me to see things like, oh, a migraine or seizures in here, because those definitely can mimic the same signs and symptoms. But what I do notice here is that the proportion of correctly identified or van positive among each of these diagnoses, the highest proportion positive is for the LVO stroke. So we see that van positive captured about 81% of those, and for the bleeds, so that was about 78% of the bleeds were captured van positive. And we talk a little bit about sensitivity and specificity, and we're going to throw around here on the next table. We'll talk about positive predictive value, negative predictive value, see if any of our panelists have any urge to speak and define those things. I know, I'm an epidemiologist, been one for a long time, still need to go look these things up. So I think that even though we've talked about it on the show before, it's probably worth going through, what is sensitivity, what is positive predictive value, and what do those mean? So I'll see if either Dr. Fernandez or Jeff want to talk about it, and if not, I'll be happy to. I'm not seeing any takers.
So let me take the first whack, and then you can tell me how I'm wrong, Dr.
Okay.
It's been my experience that if you think you understand this statistical tool, then you're wrong, because if there's not at least 3 negatives in there, it's not correct. So in the way that I understand it, sensitivity is the ability to pick up on a disease. In this case, a large vessel occlusion or a brain bleed. Specificity means how well it's able to rule out a particular disease. In this case, either a large vessel occlusion or a brain bleed. So sensitivity, picking it up, specificity, ruling the non-disease out.
And I don't get to tell you you're wrong, because that's spot on. And I think, it's helpful to hear these things expressed in different words, because sometimes we start to hear about statistics and our eyes want to glaze over and we don't want to think about it. But it's a really important concept, and it actually makes intuitive sense when we start thinking about them. So for sensitivity, we're talking about the denominator is just all of those who had the diagnosis that we're looking for. In this case, the LVO stroke. And so in this study, there were 68 of those. And then when we talk about sensitivity, we want to know what % of those 68 were captured by the test that we're using, which in this case happens to be VAN. So 55 over that 68 is going to give us our sensitivity. And then specificity, the denominator just changes to all of those who don't have the disease in question. And the numerator, or the top number, then becomes what proportion of those who truly don't have it would test VAN negative. And then on the next slide, we're going to start talking about positive predictive value and negative predictive value. And then this gets all confusing, but it's really not. This is just, again, switching the denominator. So we're talking about, given a positive test, a positive VAN in this study, what's the likelihood that I'm having an LVO stroke? And so we're going to take a look at table 2 over here. And I'll have Dr. Wampler tell us a little bit about what we saw in these results. Oh, I skipped ahead of myself. It's actually table 3, but let's talk about table 2 while we're here. And this is actually just directly comparing the VAN test to that NIH test that we talked about. And this is nicely done with a Chisquare test, comparing their performance in terms of detecting LVO negative and LVO positive. And then I like the combined category of LVO and ICH. So Dr. Wampler, what is your takeaway from table 2 here?
So this is a Chisquare. This is a way to test categorical data, which means it's either large vessel occlusion, yes or no, VAN positive, yes, no. And so it's a tool to be able to put all those into a blender, blend them up, and a result pops out. And what this is showing is that there is a greater proportion of van positive patients that had a large vessel occlusion than there was a proportion of van negative patients having a large vessel occlusion. And the p-value is 0.01, which means very, very statistically significant. And what all that means is that it's probably not completely wrong. Okay.
Good point.
Then the next couple of rows is looking at the NIH Stroke Scale. And again, the perfect test, every van positive would be a large vessel occlusion, and every van negative would be a small vessel occlusion. It didn't quite work out that way, but the Chisquare tells us that it's pretty good at identifying large vessel occlusions. It may not be great at ruling out large vessel occlusions or small vessel occlusions, but it's pretty good at identifying those that are truly large vessel occlusion. And the numbers on both cases for both van and the NIH Stroke Scale greater than 6 get even stronger when you include either large vessel occlusion or brain bleeds. Again, if we're looking for a triage tool, we want something that can identify the patient that needs to get to the comprehensive stroke center. And so when you include both of those, our statistics get a little bit better.
Absolutely. And this is that traditional 2x2 table that we talk about a lot in epidemiology. So from this table, you can calculate both sensitivity and specificity, which is a very helpful way to look at it. Now, one of the takeaways I have here from a practical sense is if we're looking at this, and I think you guys can see my cursor, if we're looking at the LVO positive row, and we look at the van positive, and then we look at the NIH positive, we see that van caught 55 of those 68 LVOs, and the NIH caught 58. So 58 versus 55. You know, statistically, there's probably a difference there, but from a practical sense, what do you all think about the trade-off in complexity? You know, does van make sense?
For you know, one dude trying to take care of a patient while you're driving to the hospital, that's exactly what we want. We want something that is as good as the gold standard and can be easily done in the austere environment and the EMS in our world.
Absolutely. And I think that's one of the complexities that we usually have to balance in EMS. You know, if it's something that we don't see that frequently, having a really complex tool is going to be challenging to apply. And so something simple like the van makes a lot of sense, or even, you know, in terms of the BFAST. And there have been some studies looking at, for example, just scoring the FAST, you know, assigning 1 point for face, arm, and speech. And you all use the BFAST. Have you looked at, or, you know, are you planning any analyses looking at, does the BFAST work as well? Or, you know, in your even anecdotal experience, is van adding something on top of the BFAST?
Yeah, so the BFAST is a stroke screening tool. It doesn't help you delineate the large vessel occlusion. That's why you need the second score, whether it be the races or van or whatever you're using for that stroke severity score, that picks up that unique set of circumstances that show cortical signs and unilateral weakness. So BFAST is good to say, yep, you got some kind of stroke, but van says, oh, this is a bad stroke or a bad bleed, and you should think about going somewhere else.
And so in your experience with this, you know, seeing that it has pretty great sensitivity, maybe a little low on the specificity, is this a scale that you all are continuing to use today, and would you recommend it to others?
I most certainly would recommend it. It's easy to teach, easy to do, and our data shows that it really helps us. So I think that it would be highly recommended, especially since there's no score sheet. There's 3 elements that you just need to evaluate. And most of our paramedics actually have this score on their badge as a badge buddy that they can just quickly reference: visual, aphasia, neglect, and then go through the checklist. And we actually just recently added this to our PCR, our electronic patient care record, as a tool that they can click, oh yeah, and it helps remind them while they're documenting that this might be a stroke severity issue that needs to go to another place.
Absolutely. And Did you all notice in the study if there were any signs that showed up more often than others? And in particular, I'm curious about neglect. That was not really part of my initial EMT training. It wasn't something I heard until I was well out of school. And so I'm wondering, were you seeing cases where neglect is present, or was it more common to see, the vision or aphasia?
So aphasia is the most common picked up because it's fairly easy to pick up. The visual test is a little more difficult, but neglect is a weirdo sign, right? Where we pick up neglect is when they have forced gaze, when their eyes are off to the right, right? That one is easily picked up, but it's not as common as aphasia. It seems, especially with where we're focusing on large vessel occlusions being in M1, M2 segments of the middle cerebral artery, that language center, which lives right there at that watershed, is one of the more sensitive areas to pick up these large vessel occlusions.
I'm glad I'm not the only one who thinks that neglect is a weirdo sign. It's one of those ones you read in the textbook and you're like, what do you mean, whose arm is this? But it's one of those ones that when you see it, you're like, that's it. So thanks for sharing that.
Yeah, it can also be as simple as you've probably had patients with neglect, you just didn't know it.
Yeah.
You ever notice when you start an IV on the paretic side, a lot of times they don't even flinch.
Yeah.
Coming from a guy that's had a lot of IVs hurt. So if they're not flinching, that should cue you in that they may have neglect or at least a severe sensory deficit to that extremity. But that's a good way of starting to, then you can go forward in testing sensation and visual acuity as well.
That's an excellent point. And I think I have neglected neglect early in my career, and now there's a lot of emphasis on it. And I think it is an interesting and important one of the signs to emphasize, just because perhaps it's not as commonly included in some of our stroke education. So, we didn't necessarily see that there was a clear winner on the best stroke scale, but we do know that performing any stroke scale is better than no stroke scale. The VAN definitely seems promising in terms of it has those favorable characteristics for a memory aid, but, I'm curious about the other side of this equation. Do you all have any feel for any idea of how often stroke screens are not applied? Because if the VAN wasn't included, they couldn't have come into this study. But I'm wondering if you all are finding ways to monitor that or have recommendations for the audience on how to look for cases that might be completely missed.
Yeah, and so that's the beauty of working with a regional system of care, because our comprehensive stroke centers know exactly who had large vessel occlusions, and they know how the patient got to the hospital. So if we had a patient that came to the hospital that was not a stroke alert, but actually had a stroke, we have automatic feedback mechanisms through the system of care to make that that connection with those regional medics.
That's so important. So could you talk a little bit more about that automatic feedback mechanism? So I've been reading a little bit in a book called Peak about how important feedback is, and that feedback takes place in a timely manner. So how do you all get the feedback to that frontline clinician about, hey, there was a stroke, this patient was actually having a stroke?
Yeah, that's a phone call to Miramontes pretty quickly. The stroke coordinator is going to give me a call and say, hey, you guys missed a stroke. I'm going, what? All right, let me look into it. Or we're going to get it as a transfer, like they took it to a primary instead of into a comprehensive. And then we meet with the medics in a no judgment zone, right? We just have a quick a meeting with the medics and say, hey, look, tell me about this call, what's going on? And oftentimes there are other factors that were at play in their decision making that aren't charted in the chart, right? They go, oh yeah, I remember that call. That's the one where we had to move all the cats and the furniture and and that's why we were on scene so long, doc. And I go, oh, okay, gotcha. But we have a discussion with them fairly quickly within a couple of shifts, hopefully, on what happened, and then we give them feedback on what happened to the patient, and then how we can improve our documentation or assessment. They usually get quizzed about the VAN score and all that stuff, and we make sure they have a badge buddy on their badge so that they can reproduce the assessment again. But when you bring a patient to the hospital, it's like taking a test and never getting the results, right? Well, if you don't know what you missed, how can you improve on next time you take the test? So I think it's really important, this feedback loop. Now ours isn't perfect and it's not automatic every time, but we hear about the misses. We hear about, the ones that went to a primary instead of a comprehensive. But it's not 100%. And then we have one staff member in my office that looks at every stroke call, looking for documentation errors and assessment errors, destination errors. So we're pretty on this stroke quality assurance process.
Oh, I love so much of what you said there, especially the part around having a no judgment zone. I think that's a key part of culture in order to have this kind of meaningful feedback. All too often our early history may have been more of looking for somebody to scold or to point out I'm better than you or you missed this, versus this true natural discussion around, hey, how can we do better? Here's some information that you don't have, or that results of the test that you took, never knowing the answer. I know that was a feeling that I had very often in my EMT career, is you drop off the patient, that was that. Never knew any more about it. So having the feedback loop with the medical director present is so important. And not only just for improving clinical care, but I think it has a role for preventing burnout. Knowing how you did on the test and being able to make yourself better is probably really meaningful when it comes to reducing provider burnout.
Yeah, and so we're going the next step with this feedback loop with the product Pulsera. We're adopting Pulsera, and we're trying to get the hospitals to buy the portion that provides feedback to all the providers that took care of the patient's care. So let's say we had an LVO stroke, they came in the ER, they got their CAT scan with the diffusion gradient, they go, oh, got an LVO, we're going to the brain lab. Well, up in the brain lab, the NeuroInterventionalist can send back down the chain, ER nurse, the medics that were on the call, the engine company, if they were involved in the Pulsera, actual pictures of the clot and the angio and all that stuff. So it's like the best millennial feedback trophy you can give. So we're working to get that established in our hospital systems. Other places may have that. Pulsera is free to get you to the ER, but the hospitals have to pay for the system to have it go from the brain lab or the cath lab or wherever back down to EMS.
It sounds like there's a lot of future research studies that will hopefully come from that project as well. I think feedback is an important area to study.
Yep.
Well, the time is flying because I think we have been having a wonderful discussion. So I want to open it one more time to our panelists, to either Jeff or Tony, if you have any last question before we do some closing thoughts.
Sure, thank you. I have a couple of questions. Again, really great study and enjoyed hearing about this, and especially that piece about feedback. So important, to know what happens to our patient after we drop them off. In terms of information sharing, I was also wondering about continuing education. I know that the paramedics were initially trained in early 2017, I believe, and you collected data for 2.5 years after that. I was wondering, is there any continuing education plan in place, maybe not during the study, but now, knowing that some of those weird signs like neglect aren't something that we think about often? And then a second related question, I don't know if you at all looked at the data and saw maybe there was reduced sensitivity and specificity later on in the study, perhaps, after that training wasn't as fresh, or did things stay pretty steady over time?
So our training model allows us very easily to adapt our training to the needs of our clinical environment. We, as the Office of the Medical Director, we own the education system. So we have all of our medics come back to us annually for continuing education refresher training. And we also have several sort of real-time distributed learning mechanisms. So we keep this in front of the medics a lot. And Dr. Miramontes mentioned before, they have a badge buddy. We have tried to systematize keeping the van in front of the medics as much as possible. With respect to degradation, we weren't able to really capture that. We had about 600 patients. I don't think gave us the granularity to be able to detect trends in it. But I think at the end of the day, we try to keep it in front of them. We give them feedback as much as it is available to us, and we give them the tools that they need to be able to make it happen, right? They've got it embedded in their PCR. They have it on their body. And there's actually also a poster on the side of the ambulance. You know, we got our stroke alert, we got our heart alert, we got our trauma alert. All of those criteria are placarded inside the units. So I think that's the key, is to figure out how to make sure that those providers are continuously engaged in that mechanism.
Very well done. Yeah, thank you. Sounds like a great
Also,
system.
we actually, as we do with EMS, we drove the van score right through the doors of the ambulance bay and into the front of the triage of every ER in town. So now every nurse, basically in our system, had to learn what van was, because they're hearing it on the radio, and they had to say, well, what's that? Oh, so now all the ERs had to learn the van score also. And interestingly enough, they're using it in their own triage areas. Nursing are doing the BFAST and VAN as a part of their initial triage of patients coming in the front door instead of ones coming through the ambulance door.
That's super interesting. And I think it's helpful to have that consistency in using the same tools. Now, I know that we are in our last few minutes, so I do want to give a second for everyone to give their final thoughts. So I'll start with Dr. Fernandez. Any final thought or question from you?
I just want to say congratulations again. This is a great study. This is a great addition to the literature, and I think y'all did a really nice job publishing this paper. So thank you, and thank you for joining us and letting us pick your brain about it a little bit. Really appreciate it.
Absolutely. And Jeff, any final thought or comment from you?
I just echo what Dr. Fernandez said. Definitely a great study, and great to see this. We know that stroke is a very, very time-sensitive condition, and getting that early treatment, especially for elbow early mechanical thrombectomy, can really improve outcomes. So great to see that this is happening. Thank you.
Absolutely. And I'm going to give the authors a chance to share any last words of wisdom or key points that you just want to highlight one more time before we go. So Dr. Wampler, I'll start with you. Anything you want our audience to be sure to take away from this?
So yeah, just a couple of things. So the VAN was really pretty good, at least as good as the gold standard for detecting large vessel occlusion. It wasn't very good at ruling out small vessel occlusions, but you know what? It was almost as good as the gold standard NIH Stroke Scale at ruling out small vessel occlusions. So the way that I interpret those results is that our medics in the back of an ambulance are just as good as the neurosurgeon in the emergency department, doing with all their fancy tools and imaging techniques and stuff like that. Our medics are just as good as they are at detecting who needs to go to the cath lab. And my other closing thought is, Dr. Crow, you mentioned earlier that this is an open access article, and the reason why this is an open access article is because it was selected as the editor's choice for this particular journal, for this edition of the journal. So imagine that an EMS article is the editor's choice in a neurosurgeon's journal. That's pretty cool.
That is way cool. And I want to congratulate you all again, because I think this is a fantastic piece, and having the open access bit is really important to make it accessible to those who may not have, the academic library access, myself included. So thank you for that. And Dr. Miramontes, I will turn it over to you. Any last thoughts that you want the audience to take away from this article?
Yeah, I think you need to look at, what we were able to pull off with our regional advisory council and how we came together to make stroke a priority. If you look at the authors list, those are NeuroInterventionalists, neurologists, Dr. Kids, the medical director of Katy in Texas. You have nurses, staff from the various hospital systems. And again, the author list reflects STRAC's ability to work together to improve patient outcomes and to make our own treatments, both in EMS and in the hospitals, better every day that we address a problem or a concern. So this is a testament to the system of care approach to a disease process and the power of what you can do with that system of care.
Absolutely. And that reminds me of the phrase, it takes a system to save a life, and it surely does. And having that data exchange between the system is so, so important. And I will thank the authors one more time for sharing their time with us today, because I think it's always so much more fun when we get to hear from those who lived the research, so to speak. And this is a fantastic contribution to the EMS evidence base and really shows these authors' dedication to performing EMS research and getting it published, which we know is no easy feat. So thank you once more on that. And I'll end with my takeaway here was something that got said very early on by Dr. Miramontes was, keep it simple. This is a simple scale. Do a complete stroke screen, and it's not enough just to do a stroke screen. We need to be looking at stroke severity now and knowing how that fits within your own system's resources, because not all systems are created alike. And then that last point about timely bidirectional feedback to the actual clinician seemed really important to me. And so thank you all again. I want to remind you all that the Education Research Journal Club podcast is happening later this week, Friday, August 27th. And we will be back here with our clinical podcast on the usual time, second Monday of the month, which will be September 13th. So thank you all for listening and look forward to chatting with you all next time.